Well, thank you so much for doing this. Megan, where are you located, by the way? I know you.
I'm in Toronto.
Oh, you're in Toronto. Okay, so that's how you know Dr. Fung. You know, that's great. So, well, first of all, obviously, we're going to talk a little bit about fasting, I would imagine. That's definitely your wheelhouse, and you guys have had some impressive results with that. And you know, this is obviously a community of people that practice a carnivorous diet, but many of them also incorporate some level of fasting. Many doing intermittent fasting, several doing a little bit longer fasts. I don't know that we have any real long extended fasters in here, but I know even some people in the meeting today are doing it. I see several of our members about that. So that's and they find that to be very effective. And so that's really interesting. So I guess I want to ask, how did you get into fasting? Can you give us a little brief background on how that occurred for you?
Yeah, absolutely. So I actually started working in Jason Fung's nephrology clinic when I was 15. He was
Wow.
a brand new nephrologist, so he was more or less a student too, and we got paired together on some research projects. So I actually started in nephrology at a very young age and continued to work in the clinic doing research throughout my studies. Once I graduated, I started to become sick. I was enjoying the perks of no longer having extreme tuition bills. So going out to dinner, enjoying making some money. And I quickly became quite ill. I gained over 80 pounds and I developed type 2 diabetes during my found freedom after school had wrapped up. Coincidentally, Jason was getting really frustrated. Things weren't adding up for him. A lot of his diabetic nephropathy patients, they were struggling with type 2 diabetes, and he was trying to do a lot of dietary counseling, and they were just becoming worse and worse. And I realized too that what we were doing wasn't helpful. And when I was finally diagnosed with type 2 diabetes after gaining all of that weight, Jason asked me if I wanted to try fasting. So I jumped on in, I started fasting, I started working on my diet, but that was a slow process. But the fasting was easy. At the time, it was easier just not to eat than to try to reinvent my diet, especially because I was feeling so terrible at the time. Within 6 months, I reversed my diabetes, my PCOS, and fatty liver disease that I was diagnosed with in childhood. And I lost all of the weight that I had gained and had started to develop a healthy body composition. So that's how I got started. Our patients were really inspired by our results, and so were our fellow nephrology colleagues. So they let us start fasting a pilot group of patients. We had incredible results with all of them. So our fellow colleagues started to refer us patients. Next thing we knew, we had 88 patients, and we started accepting referrals from outside clinics. We got so busy that we actually moved most of our program online because we couldn't handle the patient load inside the clinic.
So with regard to your own, diabetes and stuff, how long did it take you to sort of see, I guess from wherever you were, and I don't know what your blood sugar was like or where your hemoglobin A1C, how long did it take you to go from that to basically normal numbers? Assuming you got to normal numbers.
Yeah, absolutely, Sean. So my diagnosis was 6.4. So I was right on the cusp. My A1C was 6.4. And my GP, my primary care, she gave me 3 months to bring my blood sugars down, at least into the pre-diabetic range, before she said she was going to start prescribing medication. So I started off fasting thinking, oh, I'm young, it's not going to be challenging. Well, my first fast is a lot more challenging than I thought. And the first month of fasting was a little bit difficult, but I actually, over the course of 5 weeks, brought my A1C down from 6.4 to 6%, which was really motivating. And the more I stuck with the fasting, the more consistently I did it, it became easy. So I was able to keep it up. And at my 6-month follow-up with my doctor, at that point, my hemoglobin A1C had gone to 4.6%. And if I did eat some carbs, refined carbs, because my diet was still a work in process during that time, I would actually see a normal blood glucose response rather than seeing my blood sugars be like 180 2 hours later, them actually being down to 9 90 or around 92 hours after eating those carbs. So that was very promising for me. I was really excited, and we've seen some incredible, just huge jumps in A1C. We had one woman go from 9.8% to 5.6% with a combination actually of fasting and carnivore over the course of 2 months, which was just totally mind-blowing to see those types of results. So I had really quick turnaround with my type 2 diabetes.
Yeah, and that's interesting that you say that, you can handle a little bit of carbohydrate without a huge blood sugar spike, because a lot of people that are critical of, low carb diets and, maybe not so much about fasting, but certainly low carb diets, they say, well, you're not really reversing your diabetes because you still are glucose intolerant. So that's interesting that you've seen that sort of observation there. So I want to know, because some people will comment that they'll try fasting, particularly our diabetics, and they'll say that their blood sugar becomes pretty unstable. And I don't know if that's an early phenomenon. And we know in the literature that some people will see a rise in glucose, particularly early on with fasting. And it's likely, obviously, hepatic gluconeogenesis, where the liver's just saying, we got to make some energy somehow. And so what happens is that something you guys see? And is that something that stabilizes as time goes by with longer fasts or more frequent fasting, over months and months?
Yeah, that's a great question, and something that I don't think is actually discussed enough amongst myself and my Dr. Fong and my fellow fasting advocate peers. During the first 4 to 8 months, depending on the individual, if they're prone to a lot of reactive hypoglycemia, depending on the dietary modifications that they're making and the type of their fasting that they do, we do see the glucose be somewhat unstable. So if that is what we see, we try to do a lesser aggressive fasting approach, like maybe 3 24-hour fasts a week, just so things stabilize. But in the long term, we see the glucose level stabilize and start to come down quite steadily. But occasionally during an extended fast, we can see significant glucose spikes during an extended fast. And when we talk to the patients or the clients we're working with, we find that this is often correlated with a lot of physical activity on that particular day as well. So a lot more gluconeogenesis occurring.
Yeah, and I guess there's something, I know I've seen you talk something about a lot of fat, maybe fat fasting, or that's something that comes along. Do you find, and I don't know if you guys compared it, my thought with that is that, when you are completely fasting and you need energy, particularly for exercise, the liver's going to say, hey, if you're doing glycolytic exercise, we're going to give you some glucose. But if you're providing fat in there, I wonder if that blunts that response a little bit. Have you guys seen anybody yet looked at glucose numbers with people doing, a little bit of fat, on their quote unquote fat fast days? Have you seen that?
Seen the glucose levels go up during the fat fasting?
No, stabilize, be less prone to swings.
Yeah, absolutely. We do see that as well. We utilize fat fasting quite often for a various host of reasons, but we do find that it really can help stabilize the blood glucose levels, very much so.
Yeah, and I've seen, interestingly, that ketones and maybe even certain fats can actually cause glucose to drop, to lower. That's just something, because I've looked through this literature pretty extensively myself. And there's all kinds of different, just so much stuff. And I want to point out that I know you're aware that Jason and I can't remember the other physician just published a case report on fasting showing a significant. It might have been that person you discussed. It was a 9 to 9 point something down to a 5 point something. And I think the protocol was, initially they kind of ramped them up a little bit, then they got more aggressive, and then they kind of ramped them back down with the fasting. Can you talk a little bit about that particular study?
Yes, so it wasn't one of mine or Jason's patients. It was actually one of Charlene's patients. I wrote the paper and we collaborated because Charlene was reaching out to us to give some guidance on this particular individual. But this is what we commonly do with a lot of diabetic patients, especially as their dietary habits tend to be a little bit all over at the place. You find that people start to go to extremes if they're brand new to fasting, which this particular individual was. They were newer to fasting, newer to low carb, ketogenic diet. So these individuals, we'd start off slower, like a 16 or 18 hour fast, transition them into 24 hours of fasting about 3 times a week, ramp that fasting up for a period of time to 36 or 42 hours. Once we start to get ideal results in terms of medication reduction, metabolic marker improvement, then we'll scale it back down to 24 hours or 16 or 18 hours on the individual. So this was the trend that Charlene followed with her patient in terms of ramping it up, helping to stabilize blood sugar levels. She hasn't seen as many patients for fasting as Jason and I have, so we were happy to help her. So slower, making sure that everything gets nice and stabilized, that the patient sort of figures out what diet they're going to follow or gets a little bit more consistent with the diet. Then we ramp up the fasting because we predict that glucose levels have started to stabilize too with a more stable diet as well. And then we'll decrease it as the patient normalizes.
Well, I guess one thing we should point out is, particularly diabetics, there's a couple medications that we have to be particularly cautious with, sulfonylureas and insulin. Have you guys seen, really significant hypoglycemic episodes, or how do you manage those people with fasting? And do you just taper them off those medications?
Yeah, absolutely. So depending on the dosage that the patient is taking at baseline, what the intentions are with fasting, what their diet is like, we will make adjustments at the start. With these patients, we'll see them quite frequently in follow-up afterwards. So in our online program, they work with their own doctors, but our fasting team works with them weekly. We have Dr. Nadir Ali joining us too next month, so he'll start to help these patients adjust their medications. But yeah, we scale them back down. It's not uncommon if someone were to jump in and do a 7-day fast that we would just completely reduce their insulin completely, even upwards to 110 units, just take them off of it throughout the course of those 7 days. So we'll give them a schedule to help titrate their insulin, usually with sulfonylureas like glycoside or diamicron. We'll reduce it by about 50% and see how the patient responds and then modify that. And we usually wouldn't prescribe it on the fasting days unless the blood sugar levels are higher. We would try to substitute it with another medication to help.
What sort of, and I'll talk about diabetes for now, then I'm going to ask about some other stuff, but what sort of are you guys seeing improvements with diabetic retina or nephropathy and some of the other sort of, normal sequelae of diabetes, when you start doing the fasting?
Yes. So in terms of diabetic related eye conditions, that is actually something that's been quite astounding. We've actually had many patients own ophthalmologists get referrals to come to our program because they're actually so blown away by the improvement in eye disease in their patients. And that is by far one of the greatest things we've seen in terms of reversing some diabetic damage is in terms of eye disease. When it comes to like neuropathy, so nerve damage, that sometimes is hit or miss. The patients that I've found that report the most significant improvements, they're also they're not eating any processed foods, any processed carbs, fats. They're, eating a very ketogenic or even a carnivore style diet. So that's been wonderful to see those patients who do improve, but it's not consistent across the board. And I think it has a lot to do with diet as well for those individuals who don't report benefits. In terms of kidney disease, diabetic kidney disease or nephropathy, it's tough when there's a lot of proteinuria. So when the kidneys are leaking out a lot of protein, we don't find that it gets dramatically better. I've seen huge improvements in urine protein, but appears that there's already quite a lot of damage done to the kidney at that point. So when Jason or I would see a patient with, say, stage 4 chronic kidney disease and their urine protein's high, you know, we say, like, let's just do our best to keep it here and to see if we can make some minor improvements. Usually in sort of stages 2 or stage 3 CKD, depending on the urine protein levels, we may or may not see improvement. I actually had one patient, he was our very first patient we ever took off insulin. His EGFR went from 31 to 81 in the course of 8 months, which is really incredible. But he didn't have much proteinuria to start with. It was quite low at the beginning.
Do you have any type 1s that you guys typically treat, and do you do anything different with the type 1 diabetics?
Not too much, to be honest. So we have some people juvenile diabetes. We've had a lot of late onset type 1 diabetes come into our program, but we wouldn't necessarily do an extreme amount of extended fasting with these individuals, but the results are no different. The goal is to get them on the minimum amount of insulin that they require. Still same dietary protocols, very encourage a lot of time restricted eating and intermittent fasting.
Yeah, let's talk a little bit about dietary protocols, because I know you tend to be, in the low carb camp for the most part. So can you talk about some of the dietary interventions you do in addition to fasting? Because you can't, I mean, obviously you got to eat at some point, right? So.
Yes, people eating, we say that feasting and fasting, they sort of complement each other, but feasting to the point of actually eating until satiation. We find that a lot of chronic dieters, especially women, struggle with eating until satiation because they feel like they've failed. So it actually takes a lot of coaching to get these women in particular feeling comfortable with eating to feeling full. Because in their past diets, when they ate and they actually experienced satiation, they likely gained weight because there was a whole bunch of carbohydrates involved in that. But we are definitely in the lower carb camp. We try to make fasting accessible to everybody. And a big reason why is Toronto is actually the most culturally diverse city in the world. And where Jason and I are located and for business is in the most diverse niche within this city. So we do have a lot of patients who are vegetarian. Actually, about 17% of our clinic patients were vegetarian. So we try to, not niche ourselves when it comes to diet too much, but really recommend low carb. I'd say about 60%, if not more, do a ketogenic diet. And we try to drive people towards doing a ketogenic diet. Usually if an individual comes in with an autoimmune condition, any sort of thyroid disease, we will really try to get them into doing a carnivore diet or guide them there in terms of changing it up. So our nutritional education that we have prepared to go alongside our fasting materials is lower carb. We teach people how to go ketogenic. We give some insight on carnivores, although we wouldn't necessarily call our team experts. We would refer them to yourself and to some of our other carnivore friends for further education. But we do work with some real food, more lower carb paleo clients as well.
Yeah, it's interesting you say 17% of your clients are vegetarian, because I think that would be overrepresentation of what the actual population of vegetarians is. So I wonder if there's just maybe you're in a neighborhood that has more vegetarians, or if they're just more susceptible to the issues. Outside of, because obviously Jason's a nephrologist and that's where your practice starts, but you are mentioning autoimmune disease, and there's some autoimmune kidney disease, surely. But I mean, are you seeing the gamut of diseases, that we all see with the fasting protocol? So that's kind of outside of nephrology.
Yes, we see everything. I would bet all my belongings that almost every patient that comes into the clinic or comes into our online counseling has some form of undiagnosed autoimmune disease if they don't have a formally diagnosed autoimmune disease. And if they have one, they likely have many that just haven't even been diagnosed yet. So inflammation is running very high. The most common one that we see that is more or less diagnosed across the board is Hashimoto's thyroiditis. And really just reducing the inflammation in these individuals, especially women, but we're seeing it a lot in men nowadays when we check their thyroid antibodies, is just reducing that inflammation helps a tremendous amount. And we've actually been able to take a ton of thyroid patients, a ton of Hashimoto's patients off their thyroid supplementation. And carnivore approach is something that we definitely recommend to the Hashimoto's group of people in conjunction with fasting as well.
Yeah, we've seen that, here quite a bit as well. So let me ask you about the fasting. Do you tailor the fasting protocol to the patient and their disease, or is it kind of just we have a standard protocol everybody goes through?
No, fasting is definitely not one size fits all by any stretch of the imagination. Have to tailor it to the individual's condition, and you have to tailor it to their lifestyle as well, since fasting more so than changing up your diet can definitely impact, say family dynamics, for example, especially if you're the cook at home or you have young kids that you have to prepare food for, or mealtime is the only time you get with your spouse, and they're not interested in connecting with you perhaps in different ways. That mealtime is important to them. So we have to get creative with most individuals. We usually start metabolic patients off trying to do a base fast of 3 36 to 42 hour fasts a week. And we assess from there. So we see how their body responds. We've had some people, who have been on, say, around 100 units of insulin for 10 years, respond really quickly, lose weight quite easily, see reduction in inflammation, and not even need to do that much fasting. After those couple of weeks, we see their markers improve even in that short period of time, and we'll scale it back to shorter fasts, somewhere between 18 and 24 hours. For a lot of individuals, though, we find that the 36 to 42 is a good base fast, but occasionally we need to ramp it up periodically, and then we have to figure out how to fit it into their lifestyle. So for an example of a mom that I was talking to in our community this morning, her family is kind of ticked off with her missing dinner 3 nights a week. But she needs to do these longer fasts. She's postmenopausal, it's tough for her to lose weight, all kinds of hormonal deficiencies across the board because of her age group. And so let's do 2 48-hour fasts then a week, because then she's only missing dinner with her family twice a week as compared to 3 times. And they're only eating leftovers twice a week since she's the cook and doesn't want to cook while she's fasted. So we try to modify it to find you want to get the minimum effective dosage, but you still want it to fit into their lifestyle as well.
Yeah, I was going to ask, because do you find that, what's the difference between, let's say, like a 72 or longer versus, say, a 24-36, as far as what things can we see improve more aggressively? They would require that longer period of time.
Yeah, absolutely. So a 24-hour fasting period, I find for a lot of people just doesn't generate the weight loss results that they're hoping to achieve. For many people, it works wonders. My husband did it and lost 80 pounds. He was 27 at the time, and it worked great for him. The majority of our patient population are men with quite severe metabolic syndrome, or women perimenopausal, menopausal, postmenopausal. So there's a lot more hormonal complications. We just don't see the fat loss. The ketone production is non-existent usually within those 24 hours of fasting, very minimal, and they're not getting the results that they want. So we would drive it up to 36 hours, just getting them into a deeper state of ketosis. So that would be the reason for going from 24 to 36. Or for the metabolic man, perhaps just to really help drive down the insulin levels even further, especially if they're still titrating off insulin injections as well. In terms of doing, say, a few 36-hour fasts a week versus a 72-hour fast a week, I wouldn't say that there's a superior benefits perhaps of doing the 72-hour fast. During 72-hour fast, you do see human growth hormone go up more, you do experience more autophagy. But if you were to do the 36-hour fast, say 3 times a week, I wouldn't say that one approach is more superior than the other. One thing where we would perhaps recommend that an individual is doing a 72-hour fast versus say 336 is in women. And this is more so because of our ghrelin, like our hormonal ghrelin cycle, and fasting. So when between that 48 and 72-hour mark, women are producing like next to no ghrelin. So they find it very easy to fast. But that first 24 hours tends to be a little bit more difficult. And we see that ghrelin tends to be running higher. Whereas with men, we don't see the ghrelin necessarily go up as high in women or go down as low during extended fasting. So men tend to do intermittent fasting like 336 with much more ease. But a lot of women struggle with that first day, and fasting becomes painful for them. Like this is this big mental hurdle to get into because they're going to struggle with hunger so much for 36 hours. So for these individuals, they often even recognize this before we recognize it and say, it would just be so much easier if I could just stay in that fast for 3 days. Because after 36 hours, it's bearable. After 42 hours, like I don't feel hungry, like I can keep going on that fast. And by the time I get to that 3rd day, I often feel like I could continue if I wanted to. So that's one of the behavioral, sort of physiological, but behavioral reasons why we would recommend doing a 72/36s, but it depends on the individual. I chose to do 2 42-hour fasts a week and 1 24-hour fast a week as sort of my base protocol for reaching most of my health goals. And for me, I just like knowing that I could eat the next day. Somehow that made it more bearable for me. So we find that that works for a lot of people. But for those who just struggle too much, it's just better to get in the fast and stay in there for a little while.
Now, it's interesting to comment on ghrelin. Has somebody actually measured I mean, is there research out there that shows that ghrelin levels basically subside after X period of fasting? Okay.
Yes. Yeah. I think Jason commented on it in his book, The Complete Guide to Fasting, but definitely on our website, there are several blogs on the topic as well.
Do you, so there are people that have, well, I mean, if they look at some of the literature and they'll say, well, fasting is not inferior to any other method for weight loss. They, I mean, they basically equate it to calorie reduction, the standard methods, and don't find any superiority to that. Obviously, you might disagree with that. I think some of the things they're looking at are, maybe it's alternate day fasting or 5-2s, and you guys might have, say there's a difference in that. Do you find that, I mean, is it your opinion, or do you have results to say that fasting is superior to any other method for weight loss? Or I guess it depends on the outcome you're looking at, I suppose.
Yeah, so we are in the midst of publishing like 7 years worth of data right now from our clinic. But what's been really exciting is that in the last 4 years, there have been 2 RCTs, randomized controlled trials, that have come out that have compared alternate daily fasting to calorie restriction diets. And they got the same result. But what they did with alternate daily fasting is very true to what Jason and I do in the clinic. It's not this, you can eat 500 calories, you're just doing like a 20-hour fast twice a week. They did true alternate daily fasting. So the one trial that came out in 2016, they followed 2 groups of patients over the course of 32 weeks. And the alternate daily fasting group, on their fasting days, they consumed water. That was it, just water. So 0 calories on their fasting days. On their eating days, they were told to maintain their regular diet, whatever that was, do not reduce caloric intake. For the calorie restriction group, they reduced everyone's caloric intake across the board by about 450 calories. So in following these individuals over the course of 32 weeks, there were some really outstanding results. The alternate daily fast group not only lost more total body fat than the calorie restriction group, they lost more trunk fat, and their lean mass percentage went up quite a lot more significantly than the calorie restriction group, which was really interesting and just helps validate our stance that we do see people gain lean mass when they start to incorporate more like true fasting protocols like this study did. Another interesting finding from this RCT from 2016 was resting metabolic rate. So the alternate daily fast group, the true fasters, they actually saw no clinically significant change or reduction in the resting metabolic rate, whereas the calorie restriction group saw a clinically significant reduction in the resting metabolic rate over the course of 32 weeks. And this is what we see because we really practice what we believe is true intermittent fasting. We are going for periods of 24 plus hours with no food, no calories. When people are new to fasting, we definitely say, okay, have a cup of, beef bone broth to help, especially as insulin levels start to drop so dramatically and you need to replenish electrolytes. Or, okay, have a cup of coffee with a little bit of heavy whipping cream, sure. But those, we call them training wheels. And just like riding a bicycle, like when you're a toddler, it's cool to have training wheels. When you're in grade 6, it's no longer cool to be riding your bike around with training wheels. So we implement sort of the same sort of mindset with our fasting members. So at the start, sure, utilize these training wheels to help you going, but then let's get into these true periods of fasting after your body has adapted to being in a fasted state, after our insulin levels start to settle down and we're not seeing as much electrolyte loss on those fasting days.
Yeah, speaking of electrolytes, when you say, nothing but water, are electrolytes allowed on those types of things, or how does that work? I mean, particularly like later on, it sounds like maybe in the beginning, electrolytes are important. Does that continue to be important, 2 months, 3 months into this?
Yeah, absolutely. So salt is another thing. So water and salt. I'm like the queen of talking about salt, I think. But salt is a big component of it. We actually find that in the female population, especially if they have a struggle with thyroid disorders too, adding salt helps them generate higher ketone levels. And a lot of females on thyroid supplementation, particularly if they're on T3, so in desiccated thyroid or in Cytomel or a slow release T3 form, that really helps limit them get into a state of ketosis, but adding the salt does help get them into a deeper state of ketosis during a fast. So that's one of our more unique findings in that population. But we are big on salt. For the most part, we're also big on magnesium supplementation too, like threonate or biglycinate, malate, and Epsom salt baths. So we encourage, if someone's trying to do a more strict water fast, they would have water and salt. And we would encourage like Epsom salt baths or Epsom salt foot soaks during those types of fasts.
Yeah, correct me if I'm wrong, but you are not a fan, or nor do you recommend dry fasting. I know there's some people out there that recommend dry fasting. What is the concern with that? I guess dehydration, but is there any other concerns around that?
We, again, being in this really diverse area that we are, we do have a lot of patients every year practice Ramadan. So from sunrise to sunset, they're doing dry fasting. And when Ramadan is like in summer months, like it is sunny at 10 o'clock at night, like here in Toronto, I need to get blackout curtains. Like those days are long and they do just fine. But for a lot of patients, they struggle with these keto flu-like symptoms when they're new to fasting. They do have very, very high insulin levels. It's extremely common to see insulin levels over 300 picomoles per liter, which is over 45 in US units. Very high insulin, that comes down rapidly. They often get quite dehydrated. So it's just most sort of the dehydration in this group. And even though these individuals in some sense are overly nourished, because they do have a lot of excessive body fat and fat stores, a lot of them do have nutrient deficiencies too across the board. So we just try to keep their electrolytes up and try to make sure that they're hydrated.
Yeah, I mean, there's somebody in the chat asking about leg cramps and also about sleep disturbances during fasting. Do you deal with any of those things, and if so, how do you deal with them?
Yeah, absolutely. So leg cramps, we, instead of adding in potassium, it's kind of rare that we would add in potassium. We would prefer to ramp up salt, and we prefer to ramp up magnesium. Magnesium, we really look at the type of supplementation that someone is taking. My favorite, and Jason's favorite, of course, is Epsom salt baths, or magnesium oil or gel, wherever you can get that topical application of magnesium. That's very effective. We'll take a look at supplements if you're doing a bath or a foot soak with Epsom salts isn't possible, and just try to make sure that they're on a higher quality magnesium, one that gets more absorbed. So most often people take magnesium oxide because they don't really know any better. It's readily easy to purchase and very economical, but it's not very well absorbed. So we'll adjust the type of magnesium that they're on, and we'll also work with them to increase their salt, and that usually alleviates leg cramps. The number one thing that we see be a problem for people that are doing like longer intermittent fasts, like 36 or 42 hours, or periodic extended fasts, is insomnia. People feel like they're up and ready to party at 1 a.m. when they should be resting and deep sleep. And this is often due to their bodies acclimating to the high noradrenaline level that's produced when you're fasting. So when you're in a fasted state, your glycogen stores are depleted or your fuel stores are depleted, your body's going to activate your sympathetic nervous system, which will produce counter-regulatory hormones to help you access your fat stores and get you feeling good during your fast, and all of the magic happen. And one of these hormones is noradrenaline, and it's great because it helps you burn fat, it helps you maintain your great resting metabolic rate. That's why in these couple of RCTs we've seen metabolic rates be stabilized, but it can leave you feel pretty energized. So what we do is, if an individual has a lot of issues with insomnia and is just wreaking havoc on their lives, we'll scale back the fasting and we'll just really increase it slowly. Often supplementing with magnesium can help, but sometimes it's just not enough to help. So we'll ramp it up slowly, or we'll wait to ramp it up till they have a couple of weeks where it doesn't necessarily matter too much if they are experiencing some sleep deprivation. And after that 2 weeks, we find that if the person is consistent, like they just need to stick with it. Like even if you're feeling miserable, jump in there and do your other fasts. Your body acclimates to having these higher noradrenaline levels present, and sleep actually gets better. And this is the number one issue that I personally struggled with too, was sleep. And I need my sleep. I am not a nice person without it. So I struggled, but after about 2 weeks, I started to get great sleep, and it was like a switch happened. But for me, every time I increased my fasting regimen, say from like 36 to maybe 48, or if I wanted to do a 72 or a 5-day, I still struggled again. And I would work on trying to get my magnesium levels up, seeing if that helps, but it doesn't always help. I do about 4 extended fasts a year for seasonal cleaning for my body. And I pick a week where I don't necessarily have to, I'm not dependent on having good sleep. So no major conferences or presentations, no really crazy and hectic work weeks. My husband's going to be out of town, then that's a good week because you won't have to deal with grumpy Megan. But this is what we commonly see with patients. So we might stabilize sleep at a 36 or 42s, but sometime if we increase the fast for whatever reason, or their patient's own desire to do an extended fast, we'll let them know that you could experience sleep issues, just something to be mindful of. But not everybody who experiences sleep at the start of their fasting journey will experience it later on too, if they decide to do extended fasting as well. But it's just always something to be mindful of while deciding whether or not you're going to do an extended fast on any particular week.
So people are asking about concerns about adrenal function suppression, thyroid function suppression. There's people that are critical of fasting, and those are a couple of the things they do. What have you found with regard to those issues?
So I share a little bit of my personal experience. I actually have a genetic mutation for one of the enzymes that helps convert T4 to active T3. And during stressful periods in my life, this has proven to be extra problematic because it can make me quite adrenal insufficient. So I've had two major episodes in my life. One when I was in undergraduate studies in my first year of university, acclimating to exams, a mother having to have brain surgery, and just a whole bunch of stress going on at the same time, being away from home during that stress. And later on in life, more recent life, just due to some, again, other personal stress that was going on. But for the most part, if an individual is presenting with some degree of adrenal fatigue, depending on what that adrenal fatigue is, or several stages of adrenal fatigue, it will help us gauge how quickly we ramp up the fasting. I find a lot of adrenal fatigue is due to thyroid issues. And what I think is more common than not that we don't really talk too much about is just like a lot of cellular inflammation, and like the thyroid hormones not being able to engage with the cell receptors in order to be effective. And then we see symptoms of adrenal fatigue. And when if we can reduce that inflammation, then we can get the thyroid hormones engaging with the receptors, and we see the symptoms of adrenal issues start to improve. So if an individual, say stage 1 or stage 2 adrenal fatigued or HPA axis dysfunction, we would then, still go in with 24 hours of fast. If they're tolerating that well, do a 36-hour fasting. If 24 seem to be an okay spot with them, we really work on their diet and good eating habits, in the sense of trying to get them on some version of a ketogenic diet that works well with them, and making sure that they're not snacking on their eating days, teaching them about proper eating windows, and just trying to maximize any fat loss and any inflammation reduction we can on the eating days. For individuals who appear to be more on that adrenal spectrum to adrenal insufficiency, and they're starting to present with like hypoglycemia and severe hypotension, we definitely drop kick them into 42-hour fasts. We would start, 14 hours, fixing their diet, trying to reduce inflammation as much as possible through dietary and meal timing strategies, and then just slowly ramp it up. And then we find that usually if we can get the inflammation down, they're able to sustain a longer fast and start to experience weight loss. So adrenal and thyroid issues sort of come hand in hand. They work together. If one is compromised, the other one's compromised, and they usually cause the compromises in one another. But I think there's just a lot of the cellular inflammation, and there's a lot of the inability of these thyroid hormones to actually intercept with the receptors because of it. And that's why we see a lot of this adrenal fatigue. So that's what I've seen through my clinical observations, and even in my own health journey as well.
You mentioned preservation or improvement in lean muscle mass with some of the fasting studies, and I've seen the fact that growth hormone seems to peak somewhere 48, 72 hours into this. There's some concerns around mTOR, because mTOR, the stimulation of mTOR is going to be insulin, it's going to be calories, it's going to be protein, it's going to be exercise, and some will say that would drive it in the other direction. So do you recommend for somebody who's concerned about maintaining muscle mass to do some sort of maybe resistance training during the fasting period to help stimulate? Because I see that as a stimulus to tell people to hang on to muscle, whereas you could potentially start to catabolize muscle as an energy source. And so if you tell the body we need to use it, we're going to preserve it better. So is there any recommendations around training during the fasting periods?
Yeah, absolutely. So one of the quickest ways to ensure that you're going to feel like crap during your fast, and then not get great results and start to struggle with issues like seeing lean mass, is to stay sedentary. So it's to definitely stay active. But for those individuals, I've worked with several pro athletes. One of them who's most more publicly talked about his interactions with Jason and myself is UFC fighter George St. Pierre. He came to us for colitis and, for getting autophagy. And for him, we're really looking at 36 hours of fasting, and he loved the challenge of doing extended fasting as well. So how do we do that and him maintain his body composition? So we definitely encourage resistance training. George, our GSP, actually just did all of his regular training that he would usually do in a fasted state or not, and his results were quite impressive. So with pro athletes that we use, or with just healthy, active individuals, we encourage that they continue. I actually had my best weight training session ever, 96 hours into a fast, and my trainer was so blown away. She invited me to come and do a talk on fasting to the entire gym. So we encourage, absolutely, for that very, very reason, Sean, to stay active to your usual level of activity. We find most people who are sedentary to start, once they get energy from fasting, once they start to heal metabolically, they want to. So they start, doing some form of resistance training, weight training. They start to try to become fit to optimize their health.
Yeah, I've seen you comment on, again, back to diabetics, because there's a lot of discussion about how much protein is necessary or optimal, and it, depending on who you talk to, you're going to get a very different answer. And so I've seen you talk about, and I've seen this within this carnivore community, is the diabetics seem to do better with higher fat to protein ratios, but I think you said as they improve, they're able to their protein tolerance improves over time. Can you comment a little bit about protein and what diet you tend to recommend in that situation, and does it indeed change over time?
Yes, absolutely. So Jason Fung, so he's my partner. He does tend to be on the lower side of the protein spectrum, very much in line with Dr. Ron Rosedale, sort of the polar opposite of what you see with someone like Dr. Ted Nyman in terms of positioning on protein. I think it's really, really sort of patient specific. I definitely think women need more protein than, say, 0.6 grams per kilogram of body fat, especially if they're struggling with like thyroid, adrenal, autoimmune issues. They need a bit more support. So what we would typically do is I sort of assign like baseline macros to individuals and see how they respond, see how their glucose responds, see how they're feeling, and then we would adjust their protein levels accordingly. So a lot of the time for an individual, when they switch from a really high junky diet to a low carb ketogenic diet, I find that they gravitate a lot towards protein. And every now and then you'll see an individual just like eat a really big steak and then just see their blood sugar levels go up higher and report that it's almost like they ate carbs, but they didn't at that meal. So for those individuals, we would start to work their protein levels down. But over time, as they become more insulin sensitive, we do see people be able to eat quite a lot more protein than they could in their insulin resistant days, and it not affect their glucose levels or even their serum insulin levels when we check those in any sort of negative way. I was one of those individuals who would see their blood sugar go up after, I say, a 12-ounce steak, and now I can eat a 16-ounce steak and not see my blood sugar levels go up at all, or have my monthly insulin levels be affected by increased protein over time. So we just sort of experiment. I think that there are a lot of people, though, especially women, who are starting out this journey that need a little bit more support from protein than certain camps on the protein spectrum allow. And I actually have found with women in our clinic that going carnivore, they're a lot likely to eat less anyways, whereas when they're eating just sort of your regular keto, because there's a lot of inflammation present, they're more hungry, so they end up eating more and more and more. But I've never seen anyone in my clinic experience anyways, go from keto to carnivore with really ramping up protein consumption quite significantly, like at all. So that's been a really interesting finding or observation that we've come across in the clinic, and we haven't found it negatively impact any blood glucose levels either.
You know, often we see, you know, particularly diabetics, but other people with metabolic issues, obesity tends to be an issue. Do you ever find that there are people that are not obese that are benefiting from fasting protocols or dietary protocols? You know, I see sometimes rheumatoid arthritis are often very thin. We see people with autoimmune disease and digestive disease often very thin. What do you do with, you know, are you finding good results? Say, like, do you ever run into, say, like relatively lean diabetics with problems that fasting seems to help with that too?
Yeah, absolutely. So we do have a lot of very skinny diabetics that we work with. A lot of arthritis. Fasting's been really wonderful for helping with these arthritic patients. And then autoimmune conditions, just like GSP with as well, and colitis. So some other GI issues too. And with them on their eating days, we just try to make sure that they're getting in adequate protein and adequate fat. And it seems to be able to stabilize their body composition in a healthy range while we try to do this more aggressive fasting with them to help them get the health results, the reduction in inflammation that they're looking for.
Yeah, somebody was just asking about, I guess, and this is something I see, you know, within our community, is a lot of improvements in anxiety, depression, other bipolar disorder, even things like PTSD. Do you find that fasting improves that? And is there any particular fasting regimen, you know, length of time that would be better suited to that type of issue, or do you guys even deal with that much?
No, it's something that we didn't necessarily think fasting or really like doing initially when we started the things that we were trying to target with fasting, like insulin levels, for example, inflammatory markers, that we would see an improvement in these conditions. But personally, I saw a huge improvement in anxiety and depression. I think that was just from improvement in thyroid function in my case due to the fasting and the diet. But we have seen, we've had patients with bipolar disorder come off of their medications and feel very comfortable doing so, and their families as well, for long years now. So we have seen these benefits as well with fasting. In terms of fasting, like the least amount of fasting, even with a dialysis patient, the least that we typically do for the therapeutic intervention is 24 hours, 3 times a week. And their eating days are structured so that they're typically doing about a 16 to 18 hour fast on their eating days as well. And we found that's the least amount of therapeutic fasting we do, but we have had patients even in that targeted fasting range do experience improvements in their mental health.
Do you find that kind of mixing things up a bit, you know, because, you know, we talk about when we go into chronic caloric reduction, our body sort of adapts, there's metabolic slowdown. Do you find that sort of a variety of fasting approach rather than every single week doing the same thing over and over again, or does adding, you know, an occasional variation in the system seem to benefit, kind of shock the system, so to speak? Does that seem to help, or do you do that?
We are all about changing things up. Absolutely, always changing things up. Even I try to modify my diet every couple of weeks, you know, just fat and protein ratios and mixing things up. So we are big advocates of that. I find that alternate daily fasting, where you're doing like one day full fast, one day eat, one day full fast, that works very, very well, and is sometimes all that people need. But I find that women, especially with low estrogen later on in life, it's just sometimes not enough fasting. Men with a lot of severe metabolic issues and probably some undiagnosed autoimmune issues, we tend to up. So I think that's something that Jason and I are common in terms of providing feedback is, you know, if it's not getting you the results you want, it's time to change things up. So a lot of the people that we work with in our program is if there's 4 weeks in every month, we encourage people 3 of those weeks, do your base fast, do what genuinely gets you results, but 1 week try to mix things up or to change things up. And we actually had quite a few women doing 2 48-hour fasts a week, and they're getting good results. They got kind of tired of doing 2 48-hour fasts a week. So we went to sort of a modified, it's not modified, it is 1 meal a day, but we changed the meal timing up. So like Monday, Wednesday, and Friday, they're eating lunch, and Tuesday, Thursday, Saturday, they're eating dinner. So even though they're eating 1 meal a day, they're alternating the type of meal or the meal time, and that gives them between 30 and 16 hours of fasting, depending on the day. And sometimes just like, even though that's less fasting, a 30-hour fast versus a 48-hour fast, they actually would see that their weight loss would start to ramp up again by just changing the placement of those meal times. So we are, if things seem to be slowing down or not at the rate that the patient would like, we'll definitely encourage them to change things up. And one of our fasting challenges is a week of mixing things up every month.
One demographic that seems particularly challenging, particularly when it comes to, I guess, weight loss, is the menopausal female. I'm sure you see them. Is there any kind of prescription, like a general approach on how to tackle it? Because I hear all the time, it's just like you're just going to dealt a bad hand. Your hormones have just changed dramatically, and a lot of women struggle with weight loss and issues that come with that. So do you deal with those folks in a sort of different manner?
So I just try to be like perfectly upfront with them and say that you're really not going to get the results you want unless you can build your fasting muscle up to the point where you're capable of doing 36 hours 3 times a week, or 48 hours twice a week, or a 72 plus a 42. It does take longer fasting, but these women who do it, we find that over the first month, it can be nerve-wracking because they're not snacking on their eating days. They've given up a lot of foods in their mind. We always try to focus on what they can have versus what they can't have, but a lot of people continuously get caught up in that can't have. And they're doing all this fasting, which is, at the start, is an inconvenience to their lives and a sacrifice. So it can be really frustrating. So I just let them know, for that first month, you might only lose 2 pounds, and it might seem like you're putting in a whole lot of effort, but they're in there. And what we find is usually somewhere between weeks 8 and week 6, we find that their hormonal profiles change. So if we look at things like estrogen, like estradiol, it improves. So if they're deficient, we see improvements and stabilization across their hormones. And what is something that is unusual is that there's several women that we've worked with now who start to have regular menstrual cycles again. After sticking with a fasting schedule consistently. Sometimes people will just have 1 or 2 periods and then they stop. And this years, but there's been a handful of women who have started to have regular cycles again, say 5 or 7 years after quote unquote going through menopause. So we do find that these longer fasts have an interesting effect on female hormones, and that's an area of interest we're really looking at right now and trying to study and learn more. I'm currently writing a book on women and fasting targeted to that population and younger women with PCOS to explain our clinical observations and trying to explain our reasoning perhaps for why we see some of these trends in these groups.
Yeah, it seems like PCOS does seem to be a problem with hyperinsulinemia, but just back to the point, some women in menopause end up on HRT, hormone replacement therapy, some don't. Do you find any difference in the effect that fasting has on those that do and those that don't take hormone replacement?
Like traditional hormone replacement therapy, I feel like it can sometimes feel next to impossible for them to get results. I find women that are on bioidentical hormone replacement therapy get quite good results. So fasting doesn't seem to, the regular hormone replacement therapy, fasting, it helps a bit, but it's very slow and it's painful. Whereas on bioidentical hormones and fasting, women, if they're in optimal ranges, they tend to get weight loss just as fast as a healthier male just looking to lose weight.
What mistakes do you see with fasting? Do you see any people that make mistakes and they end up maybe causing more problems than they help? Is that something that you can discuss?
Yeah, so I think the biggest mistakes people make while fasting is perhaps utilizing too many training wheels when they fast, like way too much cream in their coffee, for example, is a common one that we'll see. A lot of bulletproof coffees, like multiple bulletproof coffees during the day while they're fasting. I mean, it's plenty of fat, which is good, but their body's going to fuel off of the fat in those bulletproof coffees rather than in their own body fat. So if someone's new to fasting and a bulletproof coffee in the morning helps, that's great. But if you are acclimated to fast, having, you know, 1 or 2 bulletproof coffees in the day, and you're doing like 24 or 36, we see that often be problematic for people reaching their goals. Another one that I see too is when people will sort of drink their broth very, very slowly throughout the day. So they'll like reheat it several times too, because that's how slowly that they're drinking it. And I see that being very counterproductive towards them reaching their goals.
Yeah, so it sounds like the best thing is just water, some water, salt, and that's going to be the most effective once you can get to that. So get rid of the training wheels and then just kind of do a regular fast. Megan, thank you. I mean, I don't want to monopolize any of your time. This has been tremendously informative. This has been wonderful. You're a great resource. I'm sure everybody's going to see this is going to be really, learn a lot from this. So let folks know where to find out more about you guys, your program, and that sort of stuff.
Yeah, absolutely. So you can find everything that Jason, Fun, and I are up to, and all of our social links over at thefastingmethod.com.
Okay, so fastingmethod.com, and then any social media stuff, or are you much of a social media person?
I am more Instagram. That is my demographic. And you can find me at the handle Megan J. Ramos, and it's the same on Twitter.
Is there anything else you want to share that I didn't ask you? I'm sure there's a lot of stuff, but just to give you one more opportunity, if anything else you'd like to say.
My cardinal rule is just don't snack. If you want to eat that meat or that cheese or whatever it is, eat it with your meals. And that's a great place to start with fasting as well.
Yeah, I saw a post from a dietitian saying that we should all snack. And snacking is just a small meal. And I disagree with that. But anyway, thanks for saying that. Wonderful. Thanks, Megan. Hope to find out more from you. And you guys keep up the great work, and tell Jason hi. And then Eve, I guess I talked to Eve. Was it Eve Mayer? I think who's also kind of, you guys that collaborated on a book with her as well. And so maybe we'll get her to get some more perspective on fasting. So great. It's a wonderful tool in the toolbox, and I think we're, it's just, the more we know, the healthier we can be, hopefully. So thanks again.
No problem. Thank you, Sean. Thanks, everybody.
All right, I'm going to shut it down, guys. We'll see some of you guys soon. Okay, bye, everybody.